Quadratus Lumborum block or QL block. This video is part of my truncal regional analgesia course that contained these blocks. So for each one there is a video. Feel free to watch them. So let's get started. First, I would like you to know what is Quadratus Lumborum muscle, which this block named after it. So as you see here, the Quadratus Lumborum muscle, it originates from the iliac crest and iliolumbar ligament, and it inserts on the 12th rib as well as the transverse processes of lumbar vertebrae 1, 2, 3, and 4. This muscle is supplied by subcostal nerve T12 and L1 to L4 costal processes, costal spinal nerves. The function of this nerve to flex the trunk to the same side, and when it contracts bilaterally it helps bearing down during bowel movement. The other important muscle here is the psoas major muscle, which originates from T12, as you see here, to L4, and it inserts all the way down to the femur bone, specifically the lesser trochanteric of the femur bone. So this muscle is mainly for hip joint movement, specifically flexion and external rotation of the hip. So if you look at this picture here, you see the QL muscle, the rector spinae muscle above that, and here the thin muscle of the latissimus dorsi, and underneath the QL muscle is the psoas muscle. So if we look here, that's the psoas muscle here. Behind the psoas muscle attached to the vertebral body and transverse process. So behind that you will see the lumbar plexus. So it's important to keep in mind when we are doing this process not to go farther down, because you increase your chance of getting lumbar plexus involvement. This is an axial cut here. So from the back, the rector spinae, just lateral to it, you have the latissimus dorsi. Next to it is the QL muscle here, and then again attached to the vertebral body is the psoas muscle. So, and then if you see here, you have the external oblique, internal oblique, and transversus muscle. So it's important to remember the three important fascia here, the posterior and the middle and the anterior. So when we are performing Quadratus Lumborum block, there is 3 traditional approaches to do this block. As you see here, posterior, lateral, and anterior. So it is all these names in relation to the Quadratus Lumborum. So if you put your medication just behind the muscle from the back, that's posterior. If you put it lateral, that's lateral, and if you put it anterior next to the anterior thoracocolumnar fascia, that's anterior approach. Now, this is an important picture here, show you the innervation, and this is around T12. So as you see here, it's not like when we go higher in the thoracic vertebrae. Here you have the anterior ramus of the spinal nerve bifurcate and run behind the psoas muscle, and then in front of the quadratus lumborum, then go through, then it bifurcate again. So this is important because I want you to imagine one more time. Now we are doing posterior approach and lateral approach versus anterior approach. So it makes more sense that if you do the anterior approach, you will have a better spread to the origin of the anterior ramus. Not only that, because of the facial plane between the QL muscle and the psoas muscle, if you use enough volume, this will migrate up and medial, as you see here, and you can have some parasympathetic block, or even sympathetic block. Sorry, paravertebral block, or even sympathetic block. So how we do this? We can do it in prone or sitting. It's easier to do it in the lateral position, as you see in this images. It's also easier if you flex the hip a little bit, and you may or may not support the flank from the other side based on whether your patient thin or obese. Then you have to use a curvilinear transducer for this block, and this is a block that require a good volume, so anywhere between 20 to 30 to make sure you spread and cover all these levels. Now, as I said, there are three approaches to this. The lateral approach, which is also known as the posterior transversus abdominis plane block, or TAPS block. I covered that in the TAP block video. So basically, you start scanning at the flank, and then you go medial. So medial is going toward the spine, and you follow the three layers of the external oblique, internal oblique, transversus. The reason why you start here, because you want to chase them until they meet the quadratus lumborum. So this is the aponeurosis of them, and then you inject your medication in this plane and watch it spreading around and anterior to the quadratus lumborum. Here is another picture. See the orientation of the ultrasound probe. There is this small muscle here, which is the latissimus dorsi. It can come in your way. So it depends on your angle and where exactly your transducer. But the key, you really want to see the three muscles. The second approach is the posterior approach, which is, as I mentioned, it is posterior to the QL muscle. So it depends if you are at this level. So it is between the erector spinae and the quadratus lumborum. If you are slightly lateral, then you are between the latissimus dorsi and the quadratus lumborum. And how you know? Basically by seeing the abdominal wall muscles here. The anterior approach, which is, as I said, it's probably the best and the most recommended, because if you remember when I showed you the innervation, where that ventral rami bifurcate, and how it go in top of the anterior to the Quadratus Lumborum. So it make like in this plane. So it's better to catch it there, and you have this facial plane. It help you to spread the local anesthetic toward the paravertebral space and potentially sympathetic ganglion. So again, you start scanning. This time, I recommend you start from the midline, and you see the spinous processes, and you keep going lateral this way, and then you will tilt and slide the probe until you see the Quadratus Lumborum here. This is the TP, this is the vertebral body, so this is the Quadratus Lumborum, this is the psoas muscle. And then you go to the plane between them. Notice that we are doing this at the level of L2 or L1, just under the lower rib. And you see your local anesthetic spreading here. A couple of important notes here. It's recommended that you check for vessels by doing a color Doppler. And another important thing that you really want to make sure that your tip of the needle is not in the psoas muscle, and you are not injecting in the psoas muscle, because you may get the lumbar plexus involvement and eventually lower extremity weakness. Also, the farther you go down, you increase the risk of getting lumbar plexus here. So this is another picture. Again, we're talking about the anterior. Notice that just by simple tilting of the ultrasound probe, we are pointing more medial toward the vertebral column here. So you see the TP again, the vertebral body here. And then you see the three muscles, the erector spinae, the Quadratus Lumborum, and the psoas muscle. These three muscles together, they make a sign. They call it the Shamrock sign. So again, you advance your needle. Notice the needle position here is more steep until you reach the facial plane between the Quadratus Lumborum and psoas muscle, and you inject your medication there. Now, there is a newer approach that's recently reported. There is, as far as I know, until I prepared this presentation, there is no clinical trial for this approach. It's called the subcostal anterior Quadratus Lumborum. So as the name suggests, your ultrasound probe will be in the subcostal area back, and it's directed the caudal end directed lateral, the cephalic directed medial, as you see in the picture, and you come from caudal to cephalic, and then as you see here in the cross sectional sagittal view, the needle trajectory. So this is your 12 rep, small latissimus dorsi here, erector spinae. Notice you are closer to the midline. Then Quadratus Lumborum, smaller here, and you have the psoas muscle underneath. So you want to go again anterior to the Quadratus Lumborum. The local aesthetic, as you see here, you're coming from here. That's the needle. This is the QL muscle here. So you're injecting the medication, and you see the local anesthetic spreading and even going north underneath the 12 rib. What also you can do, you can insert the catheter here. So as you see, the catheter is here, and you see the medication again spreading underneath the quadratus lumborum, anterior to the quadratus lumborum, opening the space between the QL and the psoas muscle and going underneath the rib. This technique is designed to cover surgeries with some thoracic, more sort of thoracic involvement, like incisions above the umbilical and lateral. Specifically here, we are talking about renal transplant surgery and open nephrectomy. Now, what nerves we are blocking here with the quadratus lumborum? This is a very important thing. So again, that's the lateral cutaneous branches. You really cover them very well of the thoracoabdominal nerves, all the way from, depend again on the volume, from T6 to L1. This is also become useful for the hip surgery because now you are covering T12 and L1, which cover the hip, and this is why some people like to use it even for hip replacement, again because it covers the T12 and the L1. As you see, the advantage over the tab block that you have a wider spread, and here we're talking about the classic tab block, the lateral, not the subcostal tab block. So it gives you a wider spread than the tab block. This is why it's superior for some type of surgeries. Specifically, we're talking about if this incision extended above the umbilicus. The other important point here, the potential spread of the paravertebral space. We are talking here specifically if we are doing the anterior approach, and if you are using a high volume, as I mentioned, that gives you a benefit of potential visceral pain relief and possible sympathectomy if you are doing it bilateral. So indication: lower abdominal surgery, C-section, renal transplant, nephrectomy, abdominoplasty, iliac crest bone graft, and hip surgery. Now, contraindication, as any other block: general refusal, LA, local anesthetic, allergy, infection at the site, and bleeding, and complication as with any block, plus inadvertent puncture of the intra-aortic structure, mainly the kidney, liver, spleen, bleeding. So remember, this is considered a D block when you are trying to look up the anticoagulation, when you should stop it, we should resume it. And then regarding the kidney, especially in the right side, the kidney is lower than the left side, so extra caution need to be done there not to injure the kidney. And thank you for watching.